Do you want to know how it feels like to receive a report back here in the United States? Report meaning shift report, endorsement, or handoff report. If yes, grab a piece of paper and pen and try to write as much as you can, as best as you can. And at the end of the video, I'm gonna show you the entire thing to see if you miss something or not. So try to do this while listening without looking at this first and just write everything down as much as you can. This will mimic the typical handoff report here in the US. Okay, so let's start. So this patient in 301, this is Jane Doe, but he goes with John. He's a 71-year-old female, but he identifies as a male. So he was admitted here on the 1st of February and diagnosed with perforated colon with sepsis. His main doctor is Dr. Sander, a GI doctor, and hospitalist was consulted, care of Dr. Singh, and cardio is also on board, care of Dr. Lee, to clear for the clearance for his procedure and as well as to manage his CHF and AFib. So patient is full code and he's allergic to latex and ibuprofen. Patient complained of abdominal pain for the last 3 days, accompanied with fever and weakness. So in the CT scan in the ER, they find out he has some abdominal perforation. So they decided to do a lap and repair on him on the same day. So patient has a history of DM, CHF, hypertension, hyperlipidemia, COPD, history of dementia, cabbage in 2019 with 4 stents, alcoholic. He takes 4 to 5 vodka shots per day, and the last time he drank was on the 31st. So he is on M-mines. History of AFib and sleep apnea as well. So like I told you earlier, CT showed some abdominal perforation, and they also did some X-ray which showed some mild pneumonia for him. He has a gauge 20 on the right, AC, saline lock, and a gauge 22 on the left hand. On the left hand, we're running the half-strength saline with 20K at 100. Patient is also on antibiotics. We're giving him Flagyl and Cepifime. So patient is alert oriented ×3. At night shift said he shows signs of sundowning. So he does become confused from time to time. He is assist ×1 and he's usually using a walker at home. So we're doing M-mines for him. He scores low like 2 or 3. So there's no meds order for him yet. But if his scores goes up, then you have to call the doctor for that. Okay, so bed alarm is on for him as well. Pain-wise, he's complaining of lower abdominal pain on the left side. Initially, they were giving some Norco and morphine sulfate for him. But after surgery, he came back with a PCA with a Dilaudid. We're giving him 0.2 per dose, 10 milligrams lockout, and 1 milligram dose maximum. So total for my shift was 2 milligram. He tried 15 times, 10 was completed, and 5 was denied. And I cleared the pump like 10 minutes ago. So, respiratory, he does use an oxygen at 2 liters, but baseline is on room air. He does use CPAP at home at nighttime. Breath sounds, he does have some crackles earlier, but doctor gave him some Lasix. So, Respi is on board, they give him some breathing treatments, and he's using an incentive spirometer, and he can reach like 1,000. He does have cough, but it's non-productive, and we need to collect some sputum sample from him. Vital signs wise, he does have a fever when he came in here. He's like a 102. The latest one I have is 100.1 after the surgery. Then RR was like 22 to 25. So he's on tele with oxygen. He's running AFib with a control rate of like 80s to 110. So that's the highest for me. He does have some edemas on bilateral lower legs. He's like +2 pinting edema. Pulses are okay for him. He has some SEDs on. At home, he takes Eliquis, but because of the procedure, they stopped that and they started him on Lovenox. Then his diet is a clear liquid diet, but we're allowed to give him meds now. Pills wise, he can take his pills whole. And bowel sounds for him is like a hypo. The last bowel movement was January 31st. He is incontinent, so we're using a Purewick for him. And he did complain of bilateral lower extremity weakness. Wound-wise, he has 5 lap sites with dermaban on them. They look good. And he has a stage 2 on his coccyx. And we're doing daily dressing with the Mepilex or foam dressing for that. So because of this, we have to turn him every 2 hours. And we also place an air mattress for him earlier. He's a sugar check. It's ACHS. The latest one I had was a 248 and we gave him 4 units units of insulin. Drains wise, there's a JP drain on the left side, and we drained like 40 ml serosanguinous earlier for him. Lab wise, the thing that stands out is WBC was 23.5 yesterday, and hemoglobin kind of dropped from 8.5 down to 7.9 for him. Potassium wise is 3.3. We're giving him the IV potassium runs. A patient will be undergo a fluoroscopy of abdomen for tomorrow to check for any leakage. Then he's referred to PTOT because of the weakness, and case management is on board. Patient is previously on a home health care with Progressive Agency, but now they're planning for him to bring to a subacute rehab. I think it's Apple Willows, so that's where it's gonna be, but we're still waiting for the flea cert for that. So patient is on a contact precaution because he has a history of ESBL on his urine. We still need a sputum sample from him. He's a daily weight, strict IOs, and he's a full precaution, and NPO after midnight because he's going for a procedure in the morning. So do you have any questions? So let's find out if you got everything right. So here it is. So disclaimer, this is a made-up scenario, and the report I've given you is super jump-packed with all informations, obviously for educational purposes. Typically, it's like 30% less than what I presented with you guys. But in some cases, some patients would have like this much, or some would have more, especially if you're from ICU or PCU or TCU unit. So comment down below if there are things that you missed or you did not pick up. Okay, so hopefully this helps you. Bye-bye.